Welcome everyone, and thank you for joining us for today's webinar, Electronic Prescribing for Controlled Substances, How to Meet DEA Requirements and Drive Provider Adoption. I'm Chris Higgins, Marketing Programs Manager with Imprivata, and I'll be your host for today's session. I'm excited to be joined today by Dan Borgasano, Director of Product Marketing here at Imprivata. Welcome, Dan.
Thank you, Chris.
I'm going to hand it over to Dan in just a minute, but before I do, I have a few quick housekeeping items for our audience. First, everyone who registered for today's session will receive a recording of the webinar. Second, if you have any trouble with the audio or video today, try logging out and logging back in again, which in most cases should resolve the issue. And finally, please feel free to ask any questions at any time via the Q&A panel on the right-hand side of your screen. We'll leave time at the end to get to everyone's questions. All right, that's enough for me. Turn it over to Dan to get us started.
Great, thank you very much, Chris, and good afternoon, everyone. Thank you for joining today. As Chris mentioned, we're going to be discussing electronic prescribing for controlled substances, or EPCS. We'll talk about why EPCS matters, why we're talking about it now, some of the drivers of adoption. We'll then go through the DEA requirements for EPCS, which are very specific and very complex. We'll also talk about how Imprivata Confirm ID can help you meet those requirements while also ensuring a fast workflow for your providers. And then, as Chris said, we will open it up to any questions that you might have. So let's start with why EPCS matters, why we're talking about it today. Well, first and foremost, and the reason that the DEA initially legalized electronic prescribing for controlled substances was to combat what has become a national public health epidemic, and that's the opioid abuse crisis. Seems like every day we read at a national level and even in our local communities about the rising death toll, abuse of opioids, and so the DEA legalized the ability to prescribe controlled substances, opioids or otherwise, electronically in an attempt to combat some of the forgery and diversion that was fueling this epidemic. But there are a number of other benefits to EPCS and a number of other challenges that it can address, a lot of which are associated with the use of paper prescriptions for controlled substances. So many of your organizations are likely using electronic prescribing for non-controlled substances, but your providers are forced to use paper when it comes to narcotics and other controlled substances. So that sets up an inefficient dual workflow, which can cause frustration and dissatisfaction for your providers, but as well as your patients. So now providers are forced to deal with two different types of workflows when it comes to prescribing, and patients are forced to deal with two different ways of getting their medication. And so even though 15 to 20% of all prescriptions are controlled substances, nearly 60% of the time when medication is prescribed, a controlled substance is involved. That's because patients who are getting controlled substances are often getting non-controlled, and again, the provider and patient are forced to potentially deal with a dual workflow, or in many cases what we've seen is the provider will put everything on paper as a matter of convenience for themselves as well as the patient, but that really introduces a lot of the risk around the paper-based workflow and doesn't optimize your use of electronic prescribing. And so there's also that risk of DEA number theft, fraud, and drug diversion when you have paper prescriptions. That's really fueling the opioid epidemic that we discussed. Once that piece of paper is in a patient's hand, it's very hard to track what happens to it. It can be forged, it can be copied, otherwise diverted, and again, that really fuels the opioid epidemic. So moving to electronic can make that a more secure process. And in an effort to address the opioid epidemic, there are a lot of pieces of legislation coming out at both the state and federal level that put restrictions on how and how often certain controlled substances, particularly Schedule IIs, can be prescribed. And a lot of these exacerbate the challenges of paper prescription because your providers are going to be forced to write more frequent prescriptions than they had previously. So all these challenges we talked about are, again, really exacerbated by some of these new laws, and moving to an electronic system can make those a lot easier to absorb and a lot easier to deal with from the organizations, the providers, and the patient perspective. Finally, a third major reason why we're talking about EPCS, and perhaps why we're talking about now, is the significant regulatory and industry momentum around EPCS requirements. So just a couple of weeks ago, on October 24th, the Support for Patients and Communities Act was signed into federal law. Now, this was a sweeping bill designed to implement a number of initiatives to address the opioid abuse epidemic, but one of the requirements requires EPCS, electronic prescribing, for all controlled substances prescribed through a Medicare Part D or an MAPD plan. And so the deadline to comply with that piece of the legislation is January 1st, 2021. So that program involves about 40 to 45 million Americans nationwide, and there are more than 1 million prescribers who prescribe medication through these plans. So this should really be a compelling event to move organizations to EPCS. But in addition to that, we're seeing significant momentum at the state level. So far, 13 states have passed EPCS mandates. New York was the first with its landmark I-STOP law that took effect a couple of years ago. Since then, Maine and Connecticut laws have gone into effect. And there are 10 others that will take effect over the course of the next couple of years, the most recent of which is Pennsylvania, which actually signed its EPCS requirement on the same day the federal law was signed, and the deadline to comply there is a year. And so Inpravada has a map on our website that we encourage you to visit and maybe bookmark to see the status of state regulations around EPCS. You can see, in addition to those 13 states that have passed mandates, there are a handful of others that are considering similar legislation. And then from an industry side, Walmart announced not too long ago that it will require electronic prescriptions for all controlled substances starting January 1st of 2020. So if you do send prescriptions to Walmart, keep in mind that they must be electronically prescribed for controlled substances, again, starting in just a little over a year. So as you can see, there are a number of reasons, both from the regulatory and workflow perspective, why we're seeing significant increase in adoption of EPCS. But in order to move to EPCS, you must meet the DEA requirements. Now, the DEA's goal is to establish what it refers to as non-repudiation with absolute certainty, or what we often call an auditable chain of trust. They want to make sure that the entire process, from the time the prescription is issued to the time the patient fills it, that it's an entirely secure process. And they do this so that they can minimize the risk of fraud and diversion. They want to be absolutely sure that they can trace a prescription back to its origin. And so in order to accomplish this, they have a number of unique and specific requirements that you must meet. So at a high level, the DEA says that all states must allow e-prescribing of controlled substances. Every state board of pharmacy must allow it. And to date, every state has adopted e-prescribing allowances, Schedule 2 through 5 controlled substances. And as we discussed, many states are actually starting to mandate it. In addition, the DEA says that the EMR, or the e-prescribing application from which you're issuing these prescriptions, must be certified as meeting a host of requirements, and the pharmacies must be ready and able and certified to receive EPCS orders. And so today, nearly every major EHR or e-prescribing application has a version of their software that meets the DEA requirements and that have gone through the necessary certifications. And same is true on the pharmacy side, and about 90 to 95% of pharmacies nationwide are ready to receive e-prescribing for controlled substances. And then another common requirement that folks tend to be aware of is two-factor authentication at the time of prescribing, which we'll go through in more detail. But there are a number of other significant requirements that you and your providers, your organization and your providers must meet before you can enable EPCS. Again, the DEA really wants to establish this secure chain of trust from beginning to end. So they do this in a couple of different ways. So it really all starts with a nomination process, and that's where you create the list of all providers at your organization who you want to move from paper to electronic prescribing. Once you have that list complete, there are a couple of parallel paths that need to take place. The first is identity proofing. So the DEA says that every provider who you're going to enable for EPCS must go through identity proofing, where they validate they are who they say they are, and they're authorized to prescribe controlled substances, and their medical license is in good standing, etc. Then you have to enroll whatever two-factor authentication credentials that they'll use for EPCS into the system in a way that really binds their identity to those credentials, again, to create no security gaps. Now, separate from that, there's what the DEA refers to as logical access control. And this is the process where you'll actually give permissions to use the EPCS workflow within your EHR or your prescribing application. And in that process, there are two sets of individuals that need to be involved. The first is the group that will take that nomination list and actually configure the system to give those providers permission. But then a second individual or second set of individuals needs to actually go in and validate and approve those permissions. So that's a two-step process. And that logical access controls needs to be separate from the identity proofing and credential enrollment to, again, create a separation of duties. As I mentioned, there's a two-factor authentication requirement and that happens at the time of prescribing, which we'll go into in more detail. And then all of these steps, as well as a number of other pieces of information related to the process, the prescriptions themselves, and then any anomalies or potential security incidents, all must be tracked and reported. So as you can see, there are a series of very unique and specific requirements for EPCS that you and your providers must meet before you can enable EPCS. So we'll start with a little more detail on each of these, starting with the identity proofing process. So the DEA allows two types of identity proofing: individual and institutional. So we'll start with the requirements for individual. This is where the providers will use a third-party credential service provider, CSP, or certification authority, CA, to complete the identity proofing. And they'll do this remotely, typically by going to the CA or CSP's website, and they'll be asked a series of questions, primarily based on their credit history, to validate their identity. When they successfully complete that process, the identity proofing will be complete, and their identity will be bound to the two-factor authentication credential that they'll use to sign EPCS orders. So this is the individual model. Now, if your organization is not itself a DEA registrant, if you're not an institutional practitioner, then you must use the individual identity proofing process for EPCS. However, the other model that the DEA allows is institutional identity proofing. And this is reserved for organizations that are institutional practitioners, that do have an organizational DEA registration number. Now, when it was forming its rules, the DEA realized that organizations that are institutional practitioners tend to have pretty thorough and robust credentialing processes where they do background checks on their providers, including the status of their DEA registration, whether or not they are authorized to prescribe certain controlled substances, and whether or not they're allowed to practice medicine in that particular state, etc. So the DEA said that because those processes are already in place, these institutional practitioners are allowed to conduct identity proofing in-house. They don't have to use a third party. If your organization fits that model and chooses to go this route, the identity proofing must be conducted in person. It cannot be done remotely. But all the provider has to do is show a government-issued photographic identification, and the witness to that, the administrator, will validate that identity against a list of approved providers for EPCS. So they don't have to go through that rigorous questions about their credit history, et cetera. They simply have to show a government-issued photo ID to complete the identity proofing. Now, certainly, organizations can institute more stringent policies if you'd like, but that's all that's required from a DEA perspective. Now, a record of the identity proofing must be kept for a minimum of 2 years in the institutional model. So that's the identity proofing, the two models that the DEA allows. And there's sometimes some confusion in a couple of different areas The first, and I alluded to this earlier, is do all providers need to undergo identity proofing for EPCS? These folks are already credentialed at your organization, and they're already prescribing controlled substances on paper. So do they need to go through identity proofing when you move to EPCS? And the answer is yes, and you can see the language here directly from the DEA IFR, which is the regulation that covers EPCS. You can see that all providers, again, even those who are already credentialed and using paper today for controlled substances, must go through this identity proofing when they move to EPCS. If you have new providers coming on board, you could make that part of that onboarding process, but when you make that initial switch from paper to EPCS, you do have to go out and check the identities of all your existing providers. Now, the other common question we get and concern that we get is, if we use the institutional identity proofing model, does that mean that providers and physicians will use the organization's DEA number when prescribing controlled substances? And the answer there is no. The providers will continue to use their individual DEA numbers, and that's what will continue to appear on the electronic prescription, just as it does on paper today. Now, you might have an exception where you have mid-level practitioners who don't have their own DEA number and instead use the organization's number plus that individual's unique suffix, and that would be what appears on the electronic prescription, but again, that would be just the same as it is on paper today. So having that organizational DEA number simply gives you the authority to conduct in-house identity proofing. Nowhere will that number show up on these prescriptions if the provider has their own individual DEA number. So that's the identity proofing step. Now we'll talk about the logical access control requirement, which, as I mentioned, it must be separate from the identity proofing and credential enrollment. And this is a process where you will actually give the permissions within the EPCS application to the approved list of providers, allowing them to access EPCS and prescribe controlled substances electronically. So there are two individuals or two groups of individuals that need to be assigned to manage this logical access control process. The first group will be the ones who configure the application and give the appropriate permissions to those providers within the EHR or e-prescribing application. And then a second set of individuals must then authenticate and go through an approval workflow to approve that authorization. Now, in the institute, depending on how you do the identity proofing, that will dictate the requirements for this EPCS access approver. In the institutional identity proofing model, this second individual, this EPCS access approver, does not need to be an individual DEA registrant themselves. However, if you're choosing to do the individual identity proofing, then that second individual does need to be an individual DEA registrant. So in either case, it is a two-step, two-person process, but the requirements for that EPCS access approver will change depending on which model of identity proofing that you use. So as I mentioned, the DEA also has a two-factor authentication requirement for EPCS, and this is really important to understand. Is, you know, once you go through the initial enrollment, this is the piece of EPCS that will most directly impact your provider's day-to-day workflow. So the DEA requires, at the time of prescribing, two of the following three to be entered: something the provider is, like a biometric, something they have, which is most often a token, and something they know, which is a password. Two of those three need to be entered at the time of prescribing. One common question we get is, if the provider has already logged into the EMR, say using a password, does that count? Have they entered the first factor of authentication? And the answer is no. Again, two factors at the time of prescribing. Now, I bring this up as an important point because there are a number of other second factor authentication vendors, token vendors, for example, out there that can manage just the second factor of authentication for EPCS. And oftentimes, when they do demonstrations of their solution, that's all they'll show. They won't show the need to enter that first factor, which in that case would be the EHR password typed natively into a UI, a dialog box with the EHR. And that can sometimes give the impression that all it takes is that one token, that one factor, to complete an EPCS order, when in fact all they're showing you is the piece of the workflow that they handle. So I just want to mention that as a word of caution, as I've seen that create much of the confusion that we've seen out there. It is unequivocally two-factor authentication at the time of prescribing. So that was a quick overview of all the requirements that you need to meet for EPCS. And given all of these requirements and the number of different parts of the organization that they affect and the order in which they need to happen, the question becomes, how can you meet all of those DEA requirements to comply with the EPCS regulations while also making sure you give your providers an e-prescribing workflow that they will love and that they will adopt? If you cobble together a set of disparate technologies and manual processes, it might be good enough to meet DEA requirements and check the compliance box, but that approach could lead to missteps and leaves gaps in your system. And if it's not well thought through from the clinical workflow perspective, you're at risk of replacing a bad workflow paper with an even worse one. And so that's where Imprivata Confirm ID comes in. Confirm ID is designed to be a comprehensive end-to-end solution for helping you meet all of the DEA requirements for EPCS while also ensuring a fast, convenient workflow for your providers while giving them the broadest range of innovative and creative two-factor authentication credentials so that that is as seamless as possible. So now we'll go through some of the specific features of Confirm ID and how they can help you be compliant and drive adoption for your providers. So first, starting with the identity proofing, and here we'll focus initially on the institutional identity proofing, which again must be conducted in-house or in person, excuse me. So Imprivata Confirm ID will give you a wizard-driven utility to check the identity of your providers and capture a record of that as required per the DEA, and then enroll the authentication credentials that your providers will use for EPCS. So you can see here we have a role that you can assign called Enrollment Supervisor, and this is going to be the individual, the group of individuals that will check the provider's photo ID. They will make note of it in Confirm ID in the product, as well as any other comments you might require. Some customers, for example, ask that the driver's license number be entered in at this point. And then the witness, the enrollment supervisor, will actually authenticate at this point to validate that they did check the license. Then the provider themselves will enter an authentication, and that will be their attestation that they completed this process in a compliant way, as well as to ensure that they were in fact there in person, as the DEA requires. Immediately thereafter, that enrollment supervisor will help the provider enroll the credential that they'll use for EPCS. In this example here, you can see they're enrolling their fingerprint, but they could also enroll their phone as a token. And so doing this in a supervised way does a couple of things. First, it binds the issuance of those credentials to the provider's identity and creates a record of that as is required. But it also ensures that your providers can enroll their authentication credentials correctly the first time, and they get off to a very good positive start with EPCS. And so this whole enrollment process, checking the identity, making note of it, authenticating, and then enrolling the provider's credentials, takes only about 5 or so minutes per provider. And what you'll get is a very easy automated system, and very importantly, you'll get an audit record, and you'll have reporting on all of this, which is required by the DEA. Now, Confirm ID will also support the individual identity proofing. We've partnered with DigiCert, which is a certification authority, or CA, that's been federally approved, and we enable easy individual identity proofing. And so the provider, as I mentioned previously, will use DigiCert as a third party. They can do it remotely, they can do it on their own. They'll enter a series of information, at the end of which they will be successfully identity proofed. And this makes it very easy because it is all done within the Imprivata system. You don't need to work directly at all with a third party. There's no DigiCert infrastructure or anything you need to install in your environment. There's also a great backup option here, which many CSPs or CAs don't offer. In addition to the online knowledge-based questions that come from the credit history, DigiCert also offers a notary option where a provider can upload information and have it signed by a notary, and then send it back to DigiCert for verification. And this is a great backup option if the provider, for any reason, can't complete the online questions that I mentioned. And so either way you decide to do identity proofing, Imprivata Confirm ID can support. We also enable environments if you want to use, a mix of institutional for some providers and then individual for others. The product can absolutely support that. So Confirm ID also supports the logical access control process, and specifically that second EPCS access approver. We also have a role within our system called EPCS Access Approver. And again, these are the individuals who are going to authenticate to approve the granting of permissions as part of the logical access control step. The provider will use two-factor authentication, and Confirm ID will capture a record of that, which is required for EPCS by the DEA. And so now you have a record of the identity proofing, the enrollment of credentials, and the approval of the logical access control, all in a single system, which is really important from a reporting perspective. And then, as I mentioned, Imprivata is going to give you all the different options to meet the two-factor authentication requirement for EPCS. So we support all of the available options that the DEA has for authentication. We do this to give your providers flexibility to use whatever options and whatever combinations are going to best meet different workflow requirements. For example, within the hospital at a discharge station or in a busy ED, you might want a fingerprint plus a token as the fastest option. However, when a provider is at home or another remote location, they may not have access to a fingerprint reader. So there, password plus the token is going to be the best option. Confirm ID will support all of that. In addition to which, it will recognize whatever authentication methods are available and allowed to that provider at that time. So in the scenario I just mentioned, it will know that a fingerprint reader is available, so that's what it would present to the provider. But when they're home and there is no fingerprint reader, Confirm ID will recognize that as well, and it will then present password plus the token. So not only is this important from a workflow flexibility perspective, but also backup. So because of the increasing number of state laws and the new federal requirement, paper as a backup option is no longer going to be a viable option. So we strongly recommend you have multiple options for completing this two-factor authentication step. For example, if a provider doesn't have their phone with them in the hospital, using password plus fingerprint will be available for them to complete the EPCS process. So you can see on here there are a couple of different options within the token something you have section. And I just wanted to go through a couple of those because we've made the delivery of that token much faster and more convenient than some of the legacy systems that require providers to type in that token code. So starting with hands-free authentication. This is extremely fast and extremely convenient, and when combined with fingerprint, gives your providers the ultimate in terms of speed and flexibility for completing that two-factor. So here's how it works. The provider will be in their application, they'll enter their EPCS order, and Confirm ID will ask them for the first factor of authentication. In this case, you can see it is a fingerprint biometric, but that could be a password if the provider doesn't have a fingerprint reader available. Hands-free authentication will then automatically and wirelessly retrieve the token code that's running on the provider's mobile phone. It looks just like a conventional token app, without the provider having to unlock the phone, open up the token app, manually type it over. That phone can be locked and in their pocket, and hands-free authentication will authenticate them, and the order will be signed and complete. So as you can see, using fingerprint plus hands-free authentication essentially allows your providers to complete two-factor authentication simply by putting their finger down. And this is really popular, again, in some of those higher traffic, higher volume areas like discharge stations or emergency departments or maybe some pain clinics, etc., where there is a higher volume of controlled substances being prescribed, and you want to make that two-factor as fast and seamless as possible for your providers. Now, in addition to hands-free authentication, we also have a push token notification. So while this isn't quite as fast and convenient as hands-free, it is still much faster and more convenient than manually typing over the token code. Here, after the provider enters their first factor of authentication, a password or a fingerprint, Confirm ID will send a push notification, and right from the lock screen, they can simply approve and will be authenticated. Again, no need to unlock the phone, open up that app, and manually type over that token. Now, this password plus push notification also allows EPCS anywhere because it doesn't require any hardware. So again, as you move to EPCS and as you comply with the different state and federal requirements, it's going to be really important to have an EPCS option that's available anywhere, anytime for your providers. And this push token notification makes it very easy because it is based on the provider's mobile phone. Now also, this same push token can be used as a second factor of authentication for a number of other workflows, including for remote network access, cloud applications, and others that you may be trying to protect from a security perspective. So there are additional benefits of using this token as well. And of course, Imprivata Confirm ID, maybe most importantly, is designed to be a complete, comprehensive auditing tool for all things EPCS. So as I mentioned, the DEA requires you to create audit records and be able to produce reports of all the steps we discussed: identity proofing, credential enrollment, approval of logical access control, two-factor authentication. But the DEA also asks that you track what they call potential auditable events. And these are things like failed authentications, someone trying to access the system that doesn't have authorization to do so, failed transmissions, etc. You need to be able to track those, look at them on a daily basis, and anything that is deemed a security incident has different reporting requirements back to the DEA. The combination of the reports that Confirm ID will generate, along with those that your EHR will generate, will give you all the information you need to easily identify those potential security incidents and then report them as necessary. So again, really the comprehensive back end of reporting brings all of these different steps together. So let's just talk for a minute about some customers who've kind of had success with EPCS. And so Imprivata has been working with customers for years, helping them be successful with EPCS. As you can see here, we have more than 400 customers across nearly every state that are using Confirm ID for EPCS, many of which are using it jointly with Imprivata OneSign for those of you who use our enterprise single sign-on product. Reason for that is it shares a common infrastructure, same appliances, same endpoint agents, same administrator console, same look and feel from the end user perspective. So a lot of synergies there. We have about 600,000 licensed users for EPCS, and we're processing about 11 million EPCS transactions annually. So you can see Imprivata has a lot of experience and expertise with EPCS, and maybe most importantly, a very large network of other organizations that you have access to help you implement an EPCS process that is DEA compliant as well as efficient from your provider's perspective. And so many of these customers have been able to quantify the benefits of EPCS beyond just complying with state and federal requirements. So you can see here, Geisinger, for example, calculates that it's saving nearly $1 million per month. If you look at the savings in provider time, nursing time, callbacks from the pharmacies, and other areas where the move to EPCS has really saved. And they've been able to calculate, again, about $1 million per month savings by moving from paper to EPCS. And there's a number of other metrics that other customers have used around increasing overall e-prescribing rates, because now providers have a single electronic method for prescribing all medications. Of course, a significant reduction in paper and overall saving time. So there are a number of significant quantifiable benefits of EPCS that you should realize, in addition to some of the benefits we've talked about with moving away from paper from a fraud and reducing risk perspective. And so finally, touched on this earlier, even though we've been focusing on EPCS, Confirm ID is really designed to be a more comprehensive multi-factor authentication platform in healthcare. So we talked about workflows such as remote network access to the VPN and how security is requiring multi-factor authentication for those types of workflows. And given the requirement of two-factor authentication for EPCS, that it might make sense for your organization to deploy a single solution that allows you to meet all of your multi-factor authentication needs across the enterprise. But in healthcare, there are some specific considerations that perhaps don't exist or are less relevant in other industries. For example, is the solution efficient for your users, in particular clinical users? We talked about how introducing a two-factor authentication requirement for EPCS could create a potential barrier to care and a barrier to adoption. Well, that's true of all workflows. If you put a cumbersome two-factor authentication requirement in front of your providers and other clinical staff, then you really introduce the risk of inefficiency and frustration and potential low adoption. In addition, another consideration is whether or not that solution is extensible to all workflows. We've been talking about EPCS, but there are a number of additional clinical workflows within your EHR that require second-factor authentication. And really, even beyond that, things like medical devices and mobile devices are starting to become smarter and requiring stronger authentication. And unless your solution is really purpose-built for healthcare and has integrations in all the right places, there are going to be gaps that it just simply cannot meet from a multi-factor perspective. And then finally, does that solution meet the highest standards regulating care? We all know healthcare has very specific regulations, including EPCS, such as we've been talking about. And so if you're looking at multi-factor authentication solutions and it cannot meet all of those EPCS requirements we discussed, you might be in a position where you have one solution for some of your security needs, and now you're forced to look for another solution to meet EPCS and other healthcare-specific requirements. And so Confirm ID beyond EPCS is really designed to help you meet all these considerations. It's a comprehensive multi-factor authentication platform that is purpose-built to meet all of those unique requirements for healthcare. We talked about the innovative and convenient authentication options. Those are designed to make that two-factor as seamless and invisible as possible to your providers, especially your clinical staff. Also, our ecosystem of integrations includes healthcare-specific applications, devices, etc., to make sure that you can extend Confirm ID and multi-factor authentication to your entire business and clinical environment. And as we've discussed in great detail, Confirm ID can help you meet all of the end-to-end requirements for EPCS. And more broadly, Confirm ID is part of the overall Imprivata Identity Authentication and Access Management platform, which includes our one-sign enterprise single sign-on, as well as our identity governance solution. The benefits of which are going to allow you to reduce your total cost of ownership, streamline reporting, and make it much easier both on your IT organization as well as all of your end users, because now you can manage all of these different processes, requirements, and authentication workflows from that single centralized solution. So with that, I'll now turn it back over to Chris to open it up for questions.
Great, thank you, Dan. You certainly covered a lot of information, so I hope that everyone found it to be educational. As Dan said, now is the time to get to your questions. We've received a couple already, but as a reminder, please enter your questions into the Q&A box on the right-hand side of your screen, and we'll give folks another minute or so to enter any more questions. Okay, Dan, our first question is, can any company employee be an enrollment supervisor to complete the identity proofing?
Sure. So as we talked about, the enrollment supervisor is the person who's going to check the government-issued photo ID of your providers as part of the institutional identity proofing model. The DEA does not have restrictions on who that person can be. So yes, you can make that be anyone in your organization. And in fact, speaking with a customer earlier today who said they had about 130 different individuals fill that role, and that was their way of expanding across their entire network to complete this in-person identity proofing in a way that was very efficient for their providers, instead of trying to hold central fairs or have a small number of individuals go out to all their providers. They essentially actually made all of their individual practice managers at each of their locations an enrollment supervisor to take care of that identity proofing. So there are no restrictions on who those people can be, but remember, just keep in mind that the enrollment supervisor must be separate from those setting the logical access and approving the logical access controls within your EHR.
Great, thanks, Dan. This next attendee would like to know, in reference to the 2 factors of authentication, does the badge tap and fingerprint apply to that?
Great question. So proximity badge tap is a very common form of authentication used in Imprivata OneSign, our enterprise single sign-on, which many of you are familiar with. Unfortunately, the DEA does not deem those proximity cards to be cryptographically strong enough to meet its 2-factor authentication requirement. So the badge tap cannot be used for EPCS. Now, we do see it being used for med ordering on the inpatient side and some other EHR workflows that are outside of EPCS, but for EPCS specifically, cannot use badge tap. Fingerprint certainly is allowed, but that would have to be combined with something the provider knows, like a password, or something the provider has, like their token, which can be delivered in the different ways we talked about, the hands-free authentication, the push token, or it can be used as a conventional one-time password you can manually enter.
Great, thank you. Thanks, Dan. We have another question here that asks, how often does a provider need to be identity proofed?
So that's a good question. So the DEA really leaves that up to the CA or CSP in the individual model or the organization in the institutional model. There are no requirements in the DEA IFR. However, depending on what your policies you might have at your organization in terms of how often you're reviewing a provider's DEA number or registration status, et cetera, that may dictate if you decide you need to identity proof them again. However, the DEA does have requirements around what happens when a provider loses a credential or, otherwise that credential is compromised. So, for example, if the provider loses their phone, the DEA requires that provider reports that to the department at your organization who is in charge of logical access control, and that provider's permissions to do EPCS must be revoked from the EHR, and they must, basically be removed from the logical access control step. In order to regain permission, they need to go through identity proofing again, and with a new phone, for example. At that point, they can be given permissions again in the EHR. Again, it must be approved by the second individual, and they can start doing EPCS. So there are instances where the provider will need to undergo identity proofing again.
Great, thanks. All right, Dan, we have another question. This person asks or says, doesn't the EHR have all the audit reports needed? What benefit does Imprivata add to that?
Another good question. Yes, the EHR will have a number of the reporting requirements that you're going to need, particularly around the prescriptions themselves and a lot of the information there. And depending on which EHR you have, you may get reports on the EPCS logical access approval workflows that would be repeated in Confirm ID in Imprivata. However, what Imprivata will give you is records of the identity proofing, the issuance of two-factor authentication credentials, and then all the information about the actual authentication itself, including whether or not it failed, whether or not somebody tried to use those two factors in an unauthorized way. And these, along with what the EHR will give you, can be aggregated to identify potential security incidents. But the DEA wants to see an audit report and an audit record of the checking of identity, as well as the binding of that identity to the provider's two-factor authentication credential, which will be captured in Confirm ID, but not in the EHR system.
Great, thanks, Dan. Okay, we have another question here. This one asks, if a provider gets a new phone, do they need to be identity proofed to that specific device?
Yes, they do. The token application that's running on the provider's phone has a unique serial number that's unique to that phone. So when the provider gets a new phone, they'll have to download a new version of the token app, which has a separate serial number, which then needs to be enrolled. And the DEA has this requirement because it wants to make sure that the provider who they claim to be and who is authorized to prescribe controlled substances is the one who's enrolling that phone. That's why they don't allow self-enrollment. So the provider must have their identity checked in that scenario. However, Imprivata Confirm ID does have a heightened self-enrollment capability that is fully DEA compliant. There, so long as the provider has another method of authentication that was enrolled in a supervised way, for example, a fingerprint, they can use that fingerprint to enroll a new phone. It's very fast, it's very easy. They do it through the Imprivata agent. They will enroll their new phone, and during part of that process, it will prompt them for password plus fingerprint because they are part of the EPCS policy. And this is perhaps a more efficient way of allowing them to enroll that new phone without requiring the in-person supervised enrollment. Without that piece, though, however, yes, they must undergo in-person identity proofing, or if you're using individual, they must go through that whole process, again, the online questions, etc., to prove their identity and bind that new phone to their identity.
Thanks, Dan. All right, we have another question. In terms of the reporting, this person would like to know, how long does Confirm ID store the reports and how are they accessed?
Sure. So the DEA says that most reports, most audit records for all these different processes need to be kept for a minimum of 2 years. Some state laws, well, only one to this point, New York, has more stringent policies. Some of those need to be kept for 5 years per the iStop law. Confirm ID can be configured to store audit records as long as you'd like, as long as you need them to be. It's defaulted to 2 years, but you can certainly set it to hold them for longer if you want, or if you're required to per your state law. Now, these can be accessed through the Imprivata Administrator Console, which you're familiar with if you're an Imprivata OneSign customer. It's the same admin console, and you can see there are certain policies and certain reports that are specific to EPCS where a lot of this information will be captured and can be exported for reporting purposes.
Great, thanks, Dan. We have another person that just wants some clarification on what a soft token is.
Sure. So the traditional way that you use tokens, whether it's for so any clinical workflows or any remote access type workflows, legacy tokens are typically one of two things: either a hardware token, which is a separate device, a key fob that users would carry around, and that would generate that 6-digit code that they would manually enter in for authentication. A conventional soft token is a similar concept, except it's an application on the provider's phone, where it'll generate a unique 6-digit code every 30 seconds that the provider will have to, or user will have to enter in as the second factor of authentication. And those have been sort of the traditional, conventional methods of authenticating using a token. What Imprivata has done is made that a little bit more efficient, a lot more efficient, by allowing a push token notification where they simply press accept to approve, or if they really want the ultimate in terms of speed and convenience, it can be delivered wirelessly through Bluetooth using that hands-free authentication. But certainly as an ultimate fallback, the Imprivata ID token application can be used as a conventional soft token, where again the provider will just manually enter that token code.
Great, thank you. Okay, we have another question in. This person asks, if a provider is set up for two-factor authentication for clinical workflows, in this particular instance to satisfy Ohio Board of Pharmacy Positive ID, what happens if they then sign up for EPCS and already have an Imprivata ID?
So there are a number of workflows within your EHR where a second factor authentication could be enabled, or in some cases, like in the state of Ohio, is required. These are things like, med ordering, witnessing of administration of medications, destroying meds, etc. And so there are a number of those where you could enable that second factor. Now, in those cases, those are not regulated by the DEA rules for EPCS, and those in many cases can be a single factor, including a badge tap, like we referred to earlier. However, for EPCS, you must meet all of the requirements that we discussed here today. So for this particular question and this particular instance, even though the provider is already performing these Ohio Board workflows, they must undergo all of the steps that we just talked about for EPCS. They must have their identity checked. They must have their Imprivata token enrolled in a supervised way specifically for EPCS, and then they must go through the logical access control within your EHR, including having that second individual approve that transaction. So it's almost as if they're a net new user. They must undergo all of the same processes that we talked about.
Great, thanks, Dan. Okay, we have another question. This person wants to know, can a provider enroll for more than two methods so that they can, so that if they have phone difficulties or something else, they can get by with the two others?
It's a good question, and the answer is absolutely, and we highly encourage it. So Imprivata supports fingerprint biometrics, the token, which can be delivered in all the different ways we talk about, as well as password. Two of those three need to be entered for authentication for EPCS, and we highly recommend that you enroll your providers in all three for a number of different reasons, one of which is that backup. So that if they don't have their phone on them, if they are having difficulty, if the battery dies, if they got a new phone or they're in the process of getting a new phone, they can use password plus fingerprint for two-factor authentication. So not only is it allowed, but it's highly encouraged. It also is important for EPCS anywhere, where if you're using fingerprint plus password, say in the hospital, that provider again is probably unlikely to have a FIPS-compliant fingerprint reader at home. So there, a password plus their phone as a token is going to be the most viable option for EPCS. So yes, it's best practice, absolutely, to enroll and use multiple different factors or options for two-factor authentication for EPCS.
Great, thanks, Dan. That is going to do it for our question and answer session. I just want to remind people that we will send out a recording of the webinar to anyone that registered. If we weren't able to get to your question for whatever reason, we will follow up with you offline. And with that said, I want to thank everyone again for joining us for today's presentation. This concludes our webinar. Take care.